Hi there, I'm Dr. Richard Finn from the Geffen School of Medicine at UCLA. I'm a medical oncologist, and welcome to this Preciska GI tumor board. I am joined today by a very esteemed faculty, and I'll start with introductions. Dr. Catenacci.
Hello, I'm Dan Catenacci. I'm a GI medical oncologist and director of the GI oncology program at the University of Chicago.
Hi, I'm Marty Weiser. I'm a surgical oncologist at Memorial Sloan Kettering Cancer Center in New York City.
Hi, I'm Darren Keyes. I'm both a interventional and diagnostic radiologist at the Piedmont South Imaging Center, covering 2 hospitals southwest of Atlanta.
Hi, I'm Pritesh Patel, a radiation oncologist focusing on GI malignancies at Emory University in Atlanta.
So now we have a 70-year-old gentleman with a history of metastatic prostate cancer who underwent orchiectomy and palliative radiation to the spine and prostate, currently on prednisone and abiraterone, who now comes in with a diagnosis of an unresectable pancreatic cancer, has received gemcitabine and nab-paclitaxel and stopped due to poor performance status and tolerance. And now the question for the tumor board is, what is the best next treatment option for this patient with radiation, with stereotactic body radiation treatment, SBRT, chemotherapy and radiation over 5.5 weeks, or palliative radiotherapy be favored? So how best to address this local regional problem? So the history goes back to June of 2020, when this patient was admitted for a UTI and progression of their prostate cancer, and imaging showed an incidental pancreatic mass. At this time, the ECOG performance status was 2. Medical history is significant for prostate cancer, as we mentioned, a history of AFib and heart failure with a reduced ejection fraction, hematuria and urinary retention. Patient lives with one of their children, is moderately active, and no tobacco or alcohol history. The patient did have a mother with breast cancer and a father with skin cancer. So in April 2010, patient was found to have a cord compression from metastatic prostate cancer and underwent orchiectomy and radiation to the spine and prostate. So that's over 10 years ago. Now, 10 years later, in June 2020, they're found to have progression of their prostate cancer with involvement of the bladder base and urethrovesicular junction. They are started on an abiraterone and prednisone. An MR of the abdomen and pelvis shows an incidental finding of a 2.2 centimeter hyperenhancing lesion in the pancreatic body. An endoscopic ultrasound with biopsy confirms pancreatic adenocarcinoma. And a repeat imaging now 2 months later revealed that this mass had essentially unchanged and abuts the splenic artery and splenic vein. The patient initially is started on a clinical trial with gemcitabine and nab-paclitaxel with zinc supplementation. Patient had a dose reduction of 20% due to poor performance and tolerance, and stopped chemotherapy about 4 months later in December of 2020. About 2 months later, repeat imaging is done, and they have an increase in the size of the lesion within the pancreatic body. The pancreatic mass now abuts the distal celiac axis, encases the proximal splenic artery and proximal common hepatic artery. The CT chest is stable for osseous metastatic disease from the prostate cancer and no other visceral metastases. CA19-9 has been rising. It's currently 125. PSA is well controlled. Molecular testing is done, and the tumor has a KRAS G12D mutation. And 3 mutations per megabase as far as tumor mutational burden is low. It's negative for other genetic alterations that are seen here, including BRCA, ATM, NTRK, PALB2, PD-L1, and it's microsatellite stable. So here's the imaging, the scans.
Yeah, so we've got 2 MR images. The image on the left is a T2 weighted image. The image on the right is a contrast enhanced. It looks like arterial phase T1 weighted image. And in the center of the screen, you can see the pancreas, and you could see sort of a round mass kind of in the center portion of the pancreas. And there's some atrophy of the pancreas and dilation of the duct distal to it. On the image on the right, it looks like there almost might be a second mass, but that could just be, bias from it, just seeing it on a single slice here. Not mentioned in all the descriptions, but something else that catches my eye on these films is the appearance of the liver. There's several, T2 hyperintense and T1 hyperintense enhancing lesions in the liver, which, just given these two images would, to me raise a suspicion of possible metastatic disease as well.
Would an MRI maybe delineate that, or PET scan, or?
Well, this is an MRI.
Oh, it is an MRI. Sorry, or CT.
Sometimes looking at the later phases would help delineate it. Certainly, a PET scan would be helpful. And sometimes with pancreas, if there's a lot of motion artifact in an MRI, sometimes a good high quality CT scan can help with that as well. But generally, MRI is more sensitive for detecting liver mets than CT.
So, I think for the sake of our discussion today, I mean, we could recommend perhaps a PET scan to further stage based on those findings or evaluation of other sequences. But I think we're tasked with assessing the idea that this is locally advanced in a patient who has not tolerated chemotherapy and has the comorbidity of advanced prostate cancer, though it is generally well controlled. So, for completeness, I think, Dr. Weiser, you'll support the idea that this patient is not resectable.
That's correct, yes. Looks like vascular invasion, or at least abutment to the celiac, would make it unresectable. So
now we have a patient with unresectable disease that had first-line chemotherapy with nab-paclitaxel and did not tolerate that. And now we're looking at managing this as a local problem per se. We'll start with radiation oncology. Dr. Keese, what is your take on this approach with radiation to control the disease and the expected benefits from that?
Yeah, I think radiation certainly is often used in this scenario, and I've had several patients in this situation. I think we as a tumor board want to review not only the imaging to decide about what type of radiation is safe, but also all of us to meet the patient and understand if embarking on something with a more definitive intent is warranted. And so for the sake of this conversation, maybe we'll just assume that this patient does have an appropriate functional status to sort of tolerate the treatment and be able to do what I'm asking. And so in a situation like that, if we're wanting to entertain a high dose of radiation, be it SBRT or a 5.5-week regimen, we typically want to have some way to target the radiation appropriately to where the tumor is. And that usually requires a fiducial marker implantation. So this is an EUS procedure, requires anesthesia. And again, some patients aren't candidates for that. If a metal stent were already in place, in some cases we can utilize the metal stent as a fiducial, but given the location of this body tumor, it seems maybe unlikely that this patient has a stent. So sometimes if that's not doable and the patient doesn't have good performance status or is otherwise not a candidate for anesthesia, that helps you make the decision that you really shouldn't be embarking on treatment with high dose radiation. But if they are, and you're able to place fiducials, then the next thing that's important is that there's a motion management component to the treatment that's critical. So typically that means a patient's got to be able to do a good breath hold, good inspiration breath hold. From the look of that MRI, which also requires a good inspiration, it looks like this patient was able to do it. And that sometimes is another issue for patients who have other malignancies who have an ECOG PS of 2. But let's again assume that that's possible. In that case, the way we decide about SBRT versus a longer course is really related to the distance of the tumor to the luminal GI organs. And it's critical to look at this on the axial imaging, on the coronal imaging, to determine how close the luminal GI structures, and these are the stomach, the duodenum, and the jejunum in some cases, are to the tumor. And if we can keep the radiation obviously safely away from these other GI structures, then we can go for a high dose. If there's a good distance, we typically use SBRT at my institution. I would comment that sort of the multi-institutional study that's published in this scenario with SBRT is a low dose. So 33 gray and 5 fractions is what was given in the multi-institutional study. And I think we all agree that that's a pretty low dose at this point. It's safe, that's for sure. And there may be good reasons to choose it for that reason, but it's not ablative. So if we're going for an ablation of this area and you're giving 5 treatments with SBRT, you're hoping to try to get closer to 40 or 50 gray. And it's critical, again, that the daily setup is right on in order to avoid GI toxicity from something like this. And if the tumor is close to these other organs, that's when we typically spread it out to 5.5 weeks. We use all the same SBRT techniques for imaging and treatment, but we split the radiation and keep the high dose away from the luminal GI organs. And that's how we typically approach it. And again, anywhere along the way, if we run into issues with not being able to give an optimal treatment, we switch to a palliative lower dose mode.
So, I mean, in some ways, you can argue this is all palliative, right? This patient's not curative. Is it your feeling that high dose SBRT versus low dose SBRT provides a survival advantage, or?
Well, there certainly aren't any randomized data to support that yet, but plenty of growing data. You know, some from Dr. Weiser's Memorial Sloan Kettering, some from an experience using a relatively new linear accelerator called an MR-Linac, which has an MRI built onto the radiation machine, where high doses were achieved. And so median survivals after radiation in these locally advanced cases, of course, without other malignancies, you know, now beyond 3 years, which of course is better than we've ever seen. So we think there's you know, some indication of this, but certainly no level 1 evidence at this point.
So now, Dr. Catenacci, from the medical oncology standpoint, this patient's not going to tolerate further chemotherapy, I don't think. Nab-paclitaxel is obviously easier than FOLFIRINOX. And, you know, we're looking at managing quality of life, extension of life. If we conclude that SBRT might be superior, and if it's feasible to longer course radiation, or do you feel differently that chemo radiation over a longer period of time might be superior to SBRT, or how would you address this from MedOnc?
Yeah, no, I think that the points already made, I think I would agree with, and we would certainly have reviewed this patient's case at our multidisciplinary tumor board multiple times, probably at the initial diagnosis, and probably would have embarked on a gem-abraxane approach, because as you mentioned, FOLFIRINOX probably would be too much for them. Although in our practice, it's preferred to do FOLFIRINOX if possible, despite some recent studies sort of comparing gem-abraxane and FOLFIRINOX, suggesting there may not be that much difference. But certainly the patient who couldn't tolerate FOLFIRINOX, we would go with gem-abraxane. And now we're here and he's not tolerating that. And then in the bigger context of what he's going through, this patient, with respect to another cancer, albeit, as you point out, controlled, but he does have a stage 4 prostate cancer. And so I think the real thing is, what are the goals of care for this particular patient? And certainly we would be going towards radiation earlier rather than later if there was local symptoms from his disease, from the pancreatic cancer, to palliate that. And that makes that decision a lot easier. And then, of course, we would defer to the radiation oncologists in terms of, you just heard, whether it be short course or long course, and whether they would want chemosensitization along with that or not. In the setting of where the patient hasn't progressed on gem-abraxane, may not be tolerating it well, but remains asymptomatic from their cancer, that's a different question. And potentially one might be just surveillance. One might be monotherapy gemcitabine maintenance or capecitabine maintenance, and reserving a radiation approach for if and when it is required through palliation. These would be things that we would be considering and discussing. But your point in terms of whether or not a more aggressive approach with radiation preemptively here, even in the absence of symptoms, to try to achieve a more durable control locally, is one that's reasonable. And as noted, the level 1 evidence there really is lacking, but in a robust patient, one that has that goal in mind, one could consider that as well. And these would be the discussions we would be having at our multidisciplinary tumor board.
Yeah, and I think that's a fair discussion, right? You know, it's a body lesion. He's not obstructed, probably at risk for some pain from this lesion, though that was not something that we heard about per se. It does sound like the disease has been progressing since he stopped chemotherapy. And if the patient wants to be more, I don't like to use the word aggressive because that's not fair. I think that implies that not doing anything is wrong. But if a patient wants to be maybe more proactive in discussion with the physician, and anatomically the tumor lends itself to, meaning away from other gastric lumens to minimize toxicity, perhaps high dose SBRT with aim of 40 to 50 gray would be the first choice. And if there were concerns about more toxicity, that even 33 grays over 5 days with SBRT would be preferred. Lastly, if there were still concerns over anatomic considerations, conventional radiation over 5 weeks. And if Dr. Catanacci, if they went with that approach, do you think you would add chemotherapy over 5 weeks or just do radiation alone?
I think it would be a discussion. I think in this particular patient's case where their performance status is not good, they've already demonstrated they're not tolerating at least doublet chemotherapy well, we might recommend not or against it, but it's that would be a discussion with the radiation oncologists and ourselves, and ultimately whether it would be considered, probably a capecitabine through the duration of the chemoradiation, if that was the plan.
Yeah, and I think I would agree with that, with the idea that this is a do no harm scenario, right? And we're trying to delay progression of this disease. And I think things that offer that with a reasonable approach without increasing toxicity is very appropriate.